All right, ladies and gentlemen, boys and girls, this is one of the biggest lectures we're going to have in our psychiatric course here. You have your TCAs, your SSRIs, your MAOIs, as well as your atypical antidepressants. Woo! Now, these are all considered under the classification of antidepressants, okay? So you have your anti-anxiety, your antidepressants, as well as your antipsychotics. So keep them separated, those three classes, okay? So get a piece of paper out because, guys, we're going to go one by one, really breaking down everything. And one more thing before we start. The biggest thing here is patho, guys, honestly. If you have not seen the introduction of the psychiatric medication video, it's only like 10 minutes. If you haven't seen it, go back and watch it because the biggest thing is the way that these drugs work. The way these drugs work, and I always preach to you guys, pathophysiology. If you don't know the patho, everything else is not going to make sense. It's going to be a memorization game, and it shouldn't be that way. So memorize and understand the patho, then everything else will make sense. So let's get into it. So our first one is our TCAs, which is known as our first generation antidepressants. It's what's known as your tricyclic antidepressants. And I kind of remember this as a TSA. If you guys have ever taken a flight somewhere, you would have to go through TSA security, and it's really slow. It's really drawn out, and the security process really lags. So TCAs are very slow in terms of getting to their therapeutic range. Usually takes a few weeks, if not 6 to 8 weeks, to get to their therapeutic range, which we'll get into, okay? Now, if you guys want to go ahead and write the names of these down, I circled the most common one that you will probably be tested on, and you will probably be giving in the, the clinical setting. So go ahead and pause the video, and you can write these down on a note card. But we're going to be going over the patho next. So pause it. If you don't pause it, I'm going to move over. Here we go. All right. What I recommend you guys to do is write down on a note card your patho, okay? So dopamine, norepinephrine, serotonin. Write down your little acronyms here, DOPE and SER. Because the more you go over this, the more it'll make sense, okay? So, your norepinephrine, there's a block in the reuptake. So what we're doing is we're slowing down the communication of these neurons from communicating with each other. So, also with serotonin, we are slowing down the communication problem. It's basically a prolonging of the neurotransmitters. So one side of the phone call is being delayed to the other connection because we're blocking these reuptake transmitters, okay? So with our norepinephrine, and then now we're trying to remember, what does norepinephrine do? Well, remember norepinephrine is that catecholamine, also known as Levophed in our pharmacology. Levophed or leave 'em dead, right? So norepinephrine helps to increase the heart rate, increase the blood pressure. So if we're slowing down the communication of norepinephrine, we're basically telling our body to not activate the heart as severely, not squeeze those vessels and cause the blood pressure to increase. So what happens as a side effect is we get heart dysrhythmias. We also get hypotension. And you also have dryness and anticholinergic effects. And if you guys have seen that anticholinergic video where I talk about turning on your SNS and turning off your peripheral nervous system, anticholinergic is just a fancy word for gastric juices. So you're going to be really dry, okay? That makes sense. So, your serotonin, on the other hand, what does serotonin do? Serotonin helps you sleep. It helps you have emotion, and it also helps your memory, helps you to remember things. So, if your patients are going to have a serotonin discommunication, they're going to be confused, lack of memory. With sedation, we also know that norepinephrine is our cognitive or basically alertness. So we're going to have some sedation if we are slowing down this as well as confusion. Patients are going to be like, what? And basically serotonin is going to have that memory loss. So I recommend, guys, make this little note card, put SER, put DOP, and even write down your norepinephrine on there. It's going to make life a whole lot easier. Now, you could have what's called EPSE, which are basically side effects of your TCAs. And the side effects is what's called, I put the acronym TAP. You have tardive dyskinesia, where you're licking everything and lip smacking. You have akinesis, akathiasis, as well as pseudo-Parkinson. Now, I have an entire lecture on this because this is a specific condition with these specific kind of toxicity level signs and symptoms. So write that down. You probably not even know what it means, but look at the EPSE video. It's going to make a whole lot more sense in that video. So the patient education, remember the TCA is just like your TSA, airport security. It's very slow, very long and drawn out. You have to wait in line, take your shoes off, take your belt off. Make sure you don't have any gum, tissue paper inside your pockets. Oh my gosh, it's so long. So that's why it's very slow acting. It takes 6 to 8 weeks. Now some books I found, they were like, okay, it takes 2 to 4 weeks. But the majority, I used 3 NCLEX books. 2 of them said 6 to 8 weeks. So depending on your instructor, how they want you to learn, okay? So it's very slow for your max therapeutic levels. Just like airport security is very slow. Now the thing with our antidepressants, mainly with our TCAs, but I mean honestly, it could be with any of the drugs. We're monitoring for suicide ideations. Usually in the first month, when your patients are on antidepressant medications, they're going to start feeling better. And big NCLEX question, big test questions always say, if your patients are feeling better and want to go home, what are you going to monitor for? And you're thinking like, oh, discharge planning. No, don't. It's always suicide ideations. And now you're thinking like, oh my gosh, suicide, they're feeling better. Why are they having suicide thoughts? The thing is, they're coming out of major depression. So major depression, they wouldn't want to do anything. They just want to sit like a lump on a log, not do anything. Now they're feeling a little bit better. They're still depressed. So they might have energy to do something about feeling depressed and might have enough energy to carry out their thoughts of killing themselves. Okay, so that's why we monitor suicide ideations, because your patients are coming out of major depression and having more energy to probably carry out their suicidal fantasies. So this is huge. If there's anything that you remember or take away from this, take away the slowness on therapeutic range, and also monitor for suicide ideations. Next is it's very dry. So your patients are going to be very dry. We're monitoring their eyes and nose because it has this anticholinergic effect. Very dry, very anti-juices, okay? So the GI tract is going to be very dry. Their food intake, because if your GI tract is very dry, your patients aren't going to want to eat. So with being dry, you're going to have a low blood pressure, because of our norepinephrine, we're also having low blood pressure. So your patient's getting up like orthostatic changes. They're going to sit up and then pass out. Same thing with your diuretics. All the blood sinks to the legs and your patients pass out. Okay? No cardiac meds, no MI patients. Basically, patients who've had heart attacks before can be on this. Why? Because we're limiting norepinephrine, guys. Norepinephrine is that catecholamine that helps your heart to pump. So you can't do that. Also, and honestly, this one goes for everyone. Really, everything has a weaning off. We have to wean off this, what's it called, drug. And pretty much with everything. But guys, honestly, the biggest thing here is monitor for suicide ideations, slow onset, and really one of the other things is no heart attack patients. Because why? Our norepinephrine here, ladies and gentlemen. All right, guys, let's go on into our SSRIs, which really block the serotonin.
You can get your life back and stop those all-night study sessions. Featuring our new pre-lecture videos and follow-along study guides that highlight the book for you. You can study anywhere at your own pace with our PC, tablet, and mobile software. Join thousands of successful students already using SimpleNursing.com and get to your goals faster. Less stress and more success. Get started today. Join now at SimpleNursing.com.